Good morning and welcome, everyone. My name is Eileen Davidson, and I'm a member of the Arthritis Research Canada Volunteer Arthritis Patient Advisory Board and will be your moderator for today's webinar. Before we begin, we would like to respectfully acknowledge that Arthritis Research Canada's headquarters are located on the stolen traditional territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. We express our deep gratitude to the keepers of the land. As a mom and somebody living with rheumatoid arthritis, I'm excited to learn about arthritis and pregnancy from our experts, Dr. Neda Amiri and Mary de Vera. If you're joining us for the first time, this webinar is part of the Arthritis Research Canada Educations series, which was created by the Arthritis Patient Advisory Board to share research conducted at Arthritis Research Canada. Dr. Amiri and Dr. de Vera will give a short presentation followed by a Q&A session. Please click on the Q&A icon on the lower right side of your screen to type your questions. We will also invite you to stay to the end of the webinar to watch a 7-minute video prepared for this episode. I highly suggest it. Dr. de Vera is an associate professor at the Faculty of Pharmaceutical Sciences at the University of British Columbia and is senior scientist at Arthritis Research Canada. Her research interests include medication adherence and pregnancy in rheumatic diseases. Dr. Amiri is a clinical associate professor in the Department of Medicine, Division of Rheumatology, also at UBC, and a clinician investigator with Arthritis Research Canada. Her research interests include supporting positive pregnancy outcomes in people living with rheumatic diseases. Welcome to Dr. de Vera and Dr. Amiri.
Thank you to Arthritis Research Canada and our Arthritis Patient Advisory Board for the invitation and the opportunity to share work that we're doing on arthritis and pregnancy. And I think I'd like to preface that as someone who has been doing this work for over 10 years, it really has been a call to action and a mission for me to demystify, that long-held notion that arthritis is an older person's disease. What I hope to show is that through this work, we're not only doing research, but we're also raising awareness that arthritis is truly not an older person's disease. It actually impacts females, it impacts mothers, their children, and their family. And because of that, I think it really is important that we help spread that awareness and education. And I think it's through educational research series like this that allow us to do that. So thank you all for sharing in this today. So I'm going to get right into the heart of the matter, first on what we know about arthritis and pregnancy. And I actually wondered whether I was going to say it like this, but what we know, to put it bluntly, is arthritis is actually quite sexist. And by that, I mean arthritis strikes more females than males. And here are just some of the data to demonstrate that. Juvenile idiopathic arthritis strikes 2 times more in females than in males. Rheumatoid arthritis strikes 3 times more frequently among females than males. Lupus, 9 times more common among females than males. And because of this disproportionate impact on females, we also have to consider, associated biologic impacts. We also, and that actually speaks to the impact on the ability to raise families and be pregnant. So we also know that arthritis can strike during the reproductive years. So this might be a little bit of a busy graph, but what I would just like to point you through is that the orange bars represent females, the blue bars represent males, and what you will see on this age group, the first 5 bars where you see from 20 to 44, those are, when females are most likely to be pregnant, and that's when we actually see an increasing risk of rheumatoid arthritis. And the similar pattern can be seen. So this is another graph, although I have to say I didn't create these graphs. These were prior publications. The colors are reversed. So in this case, I will orient you that the blue dots represent females and the orange dots represent males. So here you will, this is for lupus. And what you will see is that big separation, again, higher risk among females in lupus than in males, and then that risk is increasing as patients are entering their reproductive years. So very important implications for pregnancy because arthritis itself is a risk factor for adverse pregnancy outcomes. So this is another graph that I'm gonna walk you through. So this is looking at arthritis when it is when a patient might be experiencing a flare during or before pregnancy. So if you look at the number 1 at the bottom, that is when there's no risk, and anything to the right of that 1 is when we're seeing an increasing risk. So when we find that if there is a flare during pregnancy, then there is a 20% up to 20% higher risk of a cesarean section. And then same thing, if you see a flare 6 months before pregnancy, then the patient is also, 18% more likely to experience a cesarean section. So the risk of adverse outcomes increases for other outcomes. So for example, small for gestational age. So a flare during or before pregnancy, you do see up to a 50% increased risk when those are being experienced by patients. And then we see a similar pattern with preterm births. But this is all to say that it is important to have good disease control before. So that's implications for planning a pregnancy and during pregnancy. And because of that, it is important to have information on what is safe in terms of medications. So this actually brings us to the work that we've been doing at Arthritis Research Canada. And we're going to take you on a little bit of a timeline. So I've been with Arthritis Research Canada for over 10 years. And my goal for this research is to support patients with arthritis before, during, and after pregnancy. So I'm going to take you back to 2013 when I first joined the organization, and a study that I called Family Version 1.0. Back then, we really didn't have a lot of information on the safety of most arthritis medications, how they impact the health of the mom and the baby. And that is the beginning of this program, is how can we take data and look for evidence of what medications could be safe or compatible during pregnancy. So we were successful in doing these studies, which I will share with you. But then that led to, okay, we have information on safety, but then how do we translate these to patients? How do we support them so that they can take this data and apply it to their situation so that they feel supported, empowered? So we did focus groups with females with rheumatoid arthritis, again, presenting them to the data and asking them, how can we use this to support you? And then overwhelmingly from those studies, they actually emphasized the role of their partners. So we were encouraged to do interviews with partners of those females who participated in our focus groups. And then an exciting thing that's happened through this time is we've seen more and more therapies become available for arthritis patients, which continue to revolutionize treatment. But as new therapies emerge, so does the need to gather more evidence on how safe these are for the mom and baby when we're considering use before and during pregnancy. So that actually led to Family 2.0, which we initiated last year to generate evidence on these new emerging treatments for arthritis. So just to show you some of the studies that we've been able to do as part of Family 1.0, we actually had health data on all pregnancies in British Columbia from 2002 and 2012, including prescription records and also birth records through the perinatal registry. That allowed us to study over 6,000 patients with arthritis who had a birth during that period. And from that, that actually resulted in over 8,000 babies born. And just to take you through this table, we were particularly focused on biologics. Again, at that time, they had just, their use has just been increasing, and their And they have been just so promising in terms of revolutionizing arthritis treatment. And there was really a call to action on generating evidence on how safe they were for pregnancies. So when we look at females who took biologics before and during pregnancy, so that's the blue part of the table, and compared them to females with arthritis who didn't take biologics, we actually saw very reassuring evidence that there was no increased risk of preterm births, no increased risk of small for gestational age, and no risk in terms of congenital anomalies, which was pretty reassuring data that we were able to publish and share. Again, I also talked about just the importance of, how do we take this data and support patients, because it's not as easy as having data and then patients will immediately make that decision to take medications, because it is not that simple. I think a pregnancy decision is so complex. So when we did focus groups with females with arthritis, we actually asked them, what goes into that decision between, when you're family planning. And this is what they told us. It comprises just the constellation of their identity. So their desires, their fears, their beliefs, their values, their needs. Then you layer on patient factors. So when did the disease happen? What is that experience like? What is like to encounter the healthcare system? And I say this because as Dr. Amiri will share later on, that conversation about pregnancy and family planning may actually need to happen even before patients are ready for it. Again, because we know how of the importance of good disease control you need in order to have a successful pregnancy. So it really is taking into consideration just the complexity of the patient experience. And then finally, you do have to layer that onto what will happen after the pregnancy, and in the context of the family, what is motherhood going to be like, the role of the partners, and how will that family be grown and supported in the context of having to manage such a complex and disabling condition. And then finally, on top of everything else, and I say this as a woman, there is also the fact of the societal pressures on us as women. So, our identities as women, and then again, in the context of arthritis, there is so much complexity because you are adding on the burden of a chronic disease. So this just goes to show us that, researchers, we can generate this data, but then we also need to develop tools so that when we present this information for patients, we also give them decision support and other aids so that they can make the decisions that will give them agency and confidence in those decisions. At Arthritis Research Canada, there is a lot of patient involvement in research, and the patient input really is valuable. So from these focus groups I mentioned, overwhelmingly, participants told us the important roles of their partners. So we were inspired to do what we call the spin-off study, or a sequel. I think a spin-off study is a better way to describe it, where we interviewed their partners. So the females volunteered their partners, their husbands, their boyfriends to participate on one-on-one interviews with us. And actually, we were really glad we talked to these partners, because they told us the burden and the experience of supporting their partners and how to navigate that. And something that came out, I know this appears as a very busy figure, but the things that I want you to take from here is that the partners' mental health, they wanted to highlight that, because it is also hard on them. And while they're happy and they're there for their loved ones, they too need support. And again, that has implications for us as researchers and for our clinical colleagues on how do we make sure that our interactions with the patient and their partners are comprehensive and also mindful of the relationship and all the roles that are played. So I just want to share a little bit of what's happening now with Family 2.0. Again, this is research that it's in progress, and it's building and growing from Family 1.0. And our goal here is to keep up with the evidence and keep providing patients with up-to-date information on the safety of arthritis medications during pregnancy. So I'm really excited. We have great data here in British Columbia. So the health data that I presented, it is now going to be going up to 20 years of pregnancy data. And I actually just took a peek yesterday. That is now going to be representing over 500,000 females in the province and almost 1 million births. So we still don't quite have the arthritis patients numbers, but I anticipate it is going to be at least double the 6,000 that we had from Family 1.0. Some of the work that we're doing right now with Family 2.0 is just getting a lay of the land of what's been published right now on the newer arthritis therapies. So there's not a lot, so there really is a need. So this is a paper that we're just about to write up. It is looking at targeted synthetic DMARDs. So some examples are Xeljanz and Rinvoq. What has been done in terms of looking at their safety in pregnancy? Not a lot of studies to date. So again, it is a call to action for us to address that gap. And we did similar synthesis of what's being done with biosimilar disease-modifying anti-rheumatic drugs, even less evidence. So I think this is the push for myself and Dr. Amiri as we go to our own data to generate this evidence so that patients can have the information to make, again, decisions as they build and they grow families. And I think with that, I am going to turn it over to Dr. Amiri.
Thank you, Dr. Vera, and thank you for Arthritis Research Canada for hosting this webinar. I was hoping to just shift a little bit of gears and talk about our work at the Pregnancy and Rheumatic Diseases Clinic at Mary Pack Arthritis Center. So we opened up, quote unquote, this clinic back in 2017 when I first started practice. And it has been going on since then. We are hoping to, at some point, move up to the new St. Paul's Hospital once it's built. But for now, we're situated at Mary Pack. So although the clinic is housed or located in Vancouver, we are serving the population of British Columbia. And for patients who are able to travel down, we offer in-person consultation. But definitely we have done our fair share of phone and telemedicine consultation as well. The majority of the patients who are referred to the clinic are from other rheumatologists, are patients of other rheumatologists, but certainly for patients who don't have a rheumatologist or they've been lost to follow-up or they have a new onset of rheumatic disease in pregnancy. We've had referral from other internal medicine specialties, maternal fetal medicine, and obstetric and gynecology colleagues. So in terms of the team structure that we have in the clinic, I'm the rheumatologist. We've been lucky to have nursing support, so our patients always meet with our nurse as well. And being located right above in the Mary Pack building, we have access to the occupational therapy and physiotherapy services that are offered at Mary Pack, as well as psychology services. And the OT and PT services have been so very kind and expediting our patients when there is a need. So in terms of the clinic, this is considered the quaternary clinic. So there are definitely learners who attend this clinic, and we've had learners definitely from rest of the province and the rest of the country as well. So all of our rheumatology residents or trainees come through the clinic, as well as internal medicine and maternal fetal medicine trainee doctors. So these are all doctors who've basically not only have they finished their medical school, they've done 3 to 5 years of additional training, and they're going on to seeing like complicated patients throughout pregnancy. So either from a kind of maternal fetal medicine perspective, which deal with like really complicated pregnancy, or obstetrical medicine, So this is a nice way for them to get a little bit of taste of rheumatology and how rheumatic diseases or medications are managed in pregnancy. And as I mentioned, in terms of our future plans, we're hoping to have a combined rheumatology and OB clinic, especially once the new St. Paul's Hospital is built. So in terms of how we approach our patients in the clinic, we actually encourage our patients to come to the clinic before they are pregnant and even when they are 1 to 2 years before even thinking about having children, exactly for the reasons that Dr. De Vera talked about. We have guidelines in terms of what's available out there from, American College of Rheumatology, European League Against Rheumatism, in terms of how medications or how rheumatic diseases can be or should be managed through pregnancy. As you can see, the algorithm can be complicated and definitely sometimes, loses the finer touch of patients and, the patients and their specific situation. So we try to make it a little bit more in simpler terms and go through the patient in terms of their journey and basically what needs to happen before they can become pregnant and hopefully have an uneventful and successful pregnancy. So as I alluded to, we try to do a pre-pregnancy consultation. And in that consultation, we basically get a pretty thorough history in terms of where the patient has been, how their disease presented itself, and what organs presented. We all know that rheumatic disease as well, rheumatology. People may think it's limited to the joints. A lot of our diseases can be systemic, affecting the lungs, kidneys, brain, etc. So we go through that journey, and if the patient specifically has any contraindications to pregnancy. And then in terms of our discussion, we talk about what the patient can expect in terms of the effects of disease on their pregnancy and how their pregnancy can affect the disease. We review all the patient's medications, with particular attention to their disease-modifying anti-rheumatic medications, and talk about if there are any medications that need to be stopped prior to pregnancy or switched to pregnancy-compatible medications. There are some patients that carry antibodies that need specific monitoring in pregnancy. An example of this is the SSA antibody, which can present in patients with rheumatoid arthritis or Sjogren's disease and can increase the risk of what's called neonatal lupus or congenital heart block. Patients with antiphospholipid antibodies who may be at higher risk of having adverse pregnancy outcomes, such as having higher rates of hypertension or miscarriages. So if these antibodies haven't been checked, or if it's been a while since they've been checked, we certainly check these again. And then we do what's called a little bit of a potpourri, or all the miscellaneous things that really all the patients with rheumatic diseases and all the patients who are pregnant should go through. So we talk about vaccinations, cancer screening, bone health, and all of that. And definitely, I'm not a jack of all trades. So if there's a referral to any other specialties that are needed and we need some help from other colleagues, we do make those referrals as well. So then, through this pre-pregnancy visit, we hope to lay out a roadmap in terms of things that may need to happen or medications that need to be changed prior to a patient being deemed to be optimized for proceeding with pregnancy. And then we give them the so-called green light to go ahead with the pregnancy. And once the patient is pregnant, we usually become the rheumatologist for the duration of the pregnancy. And then, if they need high risk obstetrical care, maternal fetal medicine, we work in a team, arrange for fetal echocardiogram if it's needed, make sure that their disease stays hopefully in quiescence or in remission for the throughout. Then after delivery, we do a 2-month postpartum visit just to make sure there's been no flare-ups after delivery. Again, no medication adjustment needs to be made. And then we typically discharge the patient back to their own rheumatologist. So we've been lucky enough to engage in some both retrospective and what I'll talk about shortly, prospective research in this clinic. And I'd like to thank the patients for being part of this. So this was a study that we published earlier this year looking at how and if pre-pregnancy, offering pre-pregnancy consultation makes a difference for our patients. Because certainly, sometimes obviously accidents happen. Sometimes patients don't know about the clinic or not referred in time. And we wanted to compare, is there a difference between patients who get a pre-pregnancy consultations and patients who don't get a pre-pregnancy consultation? So looking at we included patients that were seen between 2017 and 2020. We had 230 patients included. The mean age of the patients was 33 years old, and about 26% of them were Caucasian. So definitely we have a diverse group of patients. In terms of disease breakdown, about 30% of our patients had lupus, 20% had RA, 12% had other connective tissue diseases, 7% had about ankylosing spondylitis. And obviously, those numbers don't add to 100 because we see a lot of rare diseases as well. So then if I can bring your attention to the right of the screen in the graph, so you can see in terms of baseline status, there were 144 patients who received pre-pregnancy consultation, and about 86 patients who did not have pre-pregnancy consultation, meaning they showed up to the clinic for their first visit and they were already pregnant. And of those 144 at the time of when we kind of closed the study, 54 of them had become pregnant. Of those 40, we had given them the green light to go ahead for pregnancy, and only 14 of the patients we had not recommended to become pregnant at the time that we had seen them initially. So in terms of the results of the study, we found that patients who had received pre-pregnancy counseling, meaning they had met with us before they were pregnant, they were less likely to experience disease flares in pregnancy, and they were less likely to have medication changes in pregnancy. And overall, they had lower disease activity in the first trimester. And then the last point is particularly important because some studies have shown that having low disease activity or remission in the first trimester can be predictive of how patients do for the rest of the pregnancy, and all of that can impact how the outcome of the pregnancy is. So in our study, thankfully, we found that there were no difference between the two groups in terms of their pregnancy outcomes. So in this study, we looked at C-section rates, postpartum hemorrhage, miscarriages, and preeclampsia. You can see that, two patients who had not, so that's 1, 2, 3, 4, fifth line down, and the line that reads preeclampsia. 2 of the patients who had not received pre-pregnancy counseling had preeclampsia, as opposed to those who had received pre-pregnancy counseling. But again, because the numbers are small, there's no obviously statistical significance that's shown. And again, thankfully, there was no difference in terms of neonatal outcomes between the two groups either. So using the same cohort, we also wanted to see how medication use differs in patients who are seen in our clinic compared to, what's been historically found actually in BC through the work that Dr. Vera and colleagues had done. So again, in the same time period between 2017 and 2020, of the patients who we saw in the clinic, about 83% of them were on disease-modifying anti-rheumatic drugs prior to pregnancy. And about 70% of them were taking their medications during pregnancy, and 50% of them were taking their medications postpartum. And overall, we demonstrated that compared to historical data, patients who attended the clinic were more likely to continue using their medication. So on the bottom part, you can see for hydroxychloroquine, 50% of the patients continued their drugs as opposed to 7% that had been historically shown. 11% continued sulfasalazine, 9% had continued azathioprine, and 21% had continued their targeted synthetic DMARDs or biologics. And this is important because we know that for those patients who can discontinue their medications, they have 49% higher chance of having a disease flare in pregnancy and a threefold increase risk of having a disease flare after delivery. So in terms of future directions, now we are for the past 2-3 years, we've established the Canadian Pregnancy and Rheumatic Diseases Registry. And if there are any of our patients who've attended the clinic have been invited to participate in this research. So the data that I've shown you was based on retrospective data, and retrospective data has limitations in terms of, you can kind of get a gauge for what the patient's disease activity was, but you can't ask all the questions that you should have asked in the past. So prospective, we know what questions we're going to ask, and we're trying to gather all the information as we go along. And specifically, we're inviting all the patients who we see in the clinic, those people who have rheumatoid arthritis, but definitely patients with connective tissue diseases, vasculitides. We do see some rare and wonderful diseases in the clinic as well. And when patients attend the clinic, especially in the pre-pregnancy visit, we invite them to join. And then as we follow them along in pregnancy, really, it's I like it because it has low burden on the patient, because we know a lot of our patients attend a lot of different appointments, a lot of different doctors, and so we don't definitely want to add to their plate in terms of what they need to do. Patients get a short trimester specific questionnaire that they fill out, just reflecting on their disease and how they're doing. And in the background, we gather information about their medications, laboratory, all of that. And we're looking to see again how medication change and how medications affect pregnancy, how medications affect the fetus and the health of the pregnancy, and how the babies of the mothers who have rheumatic diseases, how they fare. So I invite those of you who come to the clinic to definitely consider participating. And really, again, thank you so much for Arthritis Research Canada for hosting this webinar. Unfortunately, we know in general, as Dr. Vera said, arthritis is sexist, and sometimes research can be sexist as well. A lot of pregnant patients, well, almost all clinical trials exclude women who are planning pregnancy or are pregnant from the studies because of obviously safety issues, but also liability issues. So as Dr. Vera mentioned, we've made it our life mission to study this niche area. And thank you to all the patients as well.
Thank you for such an excellent presentation. I learned a lot. Now we will start the Q&A session. Remember to click the Q&A icon on the lower right side of your screen to type your questions. Note there is no chat function for today's webinar, but to ensure that we answer the most popular questions, please upvote the questions that you would like to see answered first. Simply click on the thumbs up icon beside any question that you would like our experts to answer first. We'll give that one moment to see if we get any upvotes. Otherwise, we have quite a few questions. Okay, so we'll go with the first one because it has an upvote. Do you know when patients need to hold their medications before conception?
I'm happy to take that. So it's a little bit of it is a difficult question to answer because what's the medication? So I can't really make any recommendation before I know what the medication is, but there's certainly some DMARDs, disease-modifying anti-rheumatic medications that need to be held before pregnancy, but a lot of them are also safe and should be continued through pregnancy to make sure that the patient's disease stays in remission and doesn't flare up. So maybe they can tell me what medication they were thinking of.
I think that gives an answer that they might be able to take to their own rheumatologist to discover further. We have another one that has an upvote. Is it better to change from methotrexate or do not start on methotrexate to a biologic during preconception phase of life? For example, all women of childbearing years?
let me see if I understand the question. Is it better to change from methotrexate or not to start methotrexate to a biologic? Um, so definitely we tell patients they need to be off of methotrexate, ideally for 3 months, but at least 2 months prior to pregnancy. So if a patient, if I'm understanding the question correctly, if a patient is planning to get pregnant and they're on methotrexate, and let's say the methotrexate is controlling their disease, um, it's it's a bit of a gamble, a big gamble to just come off of methotrexate and just hope for nothing to happen. So in that specific situation, yes, the methotrexate needs to be changed to a pregnancy compatible medication. I think that's what the question was getting at.
Thank you for answering that. We have another question with 2 votes, and this one I think is very important. With the research, are there plans to work with agencies to help with knowledge translation, keep health providers up to date on the most recent findings? Agencies such as Mothers Risk at Hospital for Sick Children or the Society of Gynecologists and Obstetricians of Canada?
Feel like I'll give Neda a break. I can take that. So yes, for our knowledge translation efforts, we collaborate with a lot of arthritis patient organizations, particularly APAV, but also with CAPA, the Canadian Arthritis Patient Alliance. So we actually turn a lot of our research products into I think like support documents or guiding documents that patients can take. I think we're also starting to collaborate with guided guidance document creators, like I guess the American College of Rheumatology and also the EULAR points, which have published guidelines on managing pregnancy. So to make sure that when those guidelines are updated, that our data is considered. And I think it's just creating these partnerships. So thank you for I guess just the recommendations for continue to create the partnership so that we can share the research as widely as possible.
Yes, excellent question. Now we have a part 2 to one of the questions previously asked. Is it better to avoid methotrexate altogether if you plan on having a baby? Just to clarify.
It depends. Yeah, I mean, if somebody's planning to have a child in like 2 to 5 years and they need methotrexate now for a short period or as a bridging therapy to something else, no, there's no need to avoid methotrexate altogether. The methotrexate does not affect a woman's fertility or anything. Methotrexate poses a risk to the developing fetus, and that's why we recommend being off of it 2 to 3 months prior to pregnancy for the duration of pregnancy. And we don't know how much it gets passed on to the breast milk. So we avoid methotrexate for the duration of breastfeeding as well, but it does not affect fertility.
Thank you. We're definitely getting some great questions in the Q&A portion. So just a reminder to upvote the ones that are really important to you so that we can get a lot of perspectives or questions answered. But right now, because we've got one with a bunch of 1 votes, we'll go kind of in order. Is there any information about pregnancy when both partners have autoimmune conditions? And is there any greater impact on the child if both parents have an autoimmune condition?
So without knowing what the said autoimmune condition is, assuming we're talking about our systemic autoimmune rheumatic diseases. So as you and the people in the audience may know, I think we're lucky in a sense, or maybe why it's been a little bit fine to find cures for our diseases. Our diseases are not monogenic. What I mean by that is that it's not a single gene that causes rheumatoid arthritis or lupus or Angst-Pom. We certainly have identified genes that are implicated in having certain genes or alleles that predisposes an individual to developing a disease. But fortunately or unfortunately, a lot of things need to go wrong in a person's life to develop autoimmune disease. A little bit of bad luck We certainly know some environmental factors such as smoking can be implicated in developing arthritis, different kinds of stress. So with all of that in mind is that, yes, individuals who have first degree relatives who have autoimmune diseases or arthritis are more likely to develop arthritis. But having said that, that risk in like grand scheme of things is very small. So for example, about 1% of the Canadian population has rheumatoid arthritis, or you can say a lifetime risk of somebody's risk of developing rheumatoid arthritis around 1%. So somebody who has parents who have rheumatoid arthritis, their risk of developing is 2 times higher or 2%, right? So when I say if the risk goes up by like 100% or 200%, that sounds very dramatic, but at the grand scheme of things, their risk is around 2%, 3%. And there's a 90% plus chance of them not ever developing any autoimmune disease, right? So, we know that like for something like rheumatoid arthritis, and definitely just, I say to the patients, you shouldn't fear about like passing your disease to the patient because of all these different things that need to happen in a person's life. But I totally understand where their concerns come from.
I absolutely do too. I think one of the second questions I asked my rheumatologist, what are the chances of my son getting this? And similar answer to what you gave us. So I think that's a very important question. We have another question that has been upvoted. Is it safe to breastfeed while on arthritis medications?
We're lucky to have so many different arthritis medications, and there are definitely a lot of medications on which we can breastfeed, but I need to know the name of the medications where I can say with certainty.
Thank you. I think another question to specifically ask your rheumatologist. All right, we have another. Can you still get pregnant naturally if you have poor egg quality due to or RA medications?
So egg quality is not my area of expertise, and certainly if the individual has seen a assisted reproductive technologist specialist or something, they can give more advice. So I'm not sure if they're talking about like AMH levels or something, anti-malarial hormonal levels, and some studies show that women with arthritis may have lower AMH levels. Again, it's possible, but the reproductive endocrinologist can give them the specific numbers. Really, at the end of the day, you need one egg and one sperm to do the job, right? But it's certainly some studies, and I think one of the other questions is alluding to that. Some studies have identified that patients with certain types of arthritis, such as rheumatoid arthritis or ankylosing spondylitis, especially when the disease is not well controlled, those patients have a harder time getting pregnant. Not necessarily being kind of infertile, but they use the term like subfertility or just taking longer to get pregnant. Some of that we know to be related to perhaps use of non-steroidal anti-inflammatory medications like Advil, ibuprofen, Aleve, naproxen, because we know using a lot of those medications can interfere with ovulation. But some of that also seems to be related to the disease and the disease activity.
Thank you for that answer. We have another question. We have quite a few questions. One that has 3 upvotes. What are the reasons you know of so far as to why pregnancy and birth can trigger or turn on rheumatoid arthritis? I developed RA after the birth of my first child and have read that this is common. Do hormones have anything to do with this? And also raising my hand because this happened to me too.
Yeah, I hear this so much and obviously see it a lot. Hormones for sure. We know estrogen can affect our immune system, and obviously in pregnancy, we have higher estrogen levels, and there's a period of like pregnancy in a way is an immunosuppressed state in a sense that, you know, you have this like foreign thing growing in you and your body needs to not reject it, right? So your body is tolerating the fetus for 9 months. And, you know, again, because of those hormonal changes and the changes in the immune system, yes, some patients with arthritis and specifically rheumatoid arthritis tend to get better. We know some other arthritis like lupus, that's definitely not the case. And if anything, they can get worse in pregnancy, right? So yeah, and then after pregnancy, when that the immune system shifts and kind of goes to that pre-pregnant state with that like crash in the estrogen, yes, the two peaks in a woman's life where they're more likely to be diagnosed with an autoimmune disease, specifically rheumatoid arthritis, is after delivery and after menopause, when we see those big hormonal shifts.
Thank you. And we have another question from Jennifer Pilak, who is actually the wonderful video that you will be watching shortly. What do we know about going into remission with pregnancy? This is currently what I'm experiencing, though she's still on her DMARD medications. I'm curious to know if there's research on this and whether this impacts remission continuing or not post-pregnancy. My rheumatologist has let me know to expect possible flare-ups a few months postpartum, but I have also read anecdotally that some women find they remain in remission for quite some time post-pregnancy.
Yeah, I think this question ties in really well with the one we just kind of reviewed, is that, yeah, rheumatoid arthritis, particularly, some patients find that in pregnancy they feel a bit better. But again, if we're talking, I'm not sure what kind of arthritis, you know, different patients may have, but like with rheumatoid arthritis, for patients who come off of their medications, and even though they're doing well during pregnancy, again, because of that relative immunosuppressed state that the pregnancy offers, over 50% of them, and some studies report upwards of 90%, unfortunately, can expect a flare postpartum. Now, it's hard to know when that postpartum flare is going to come. I say anytime in the first years. It can be sometime in the first 3 months or up to a few months later.
Thank you for that answer. And we have a question from a male perspective. What do you advise the partners of persons who wish to become pregnant, i.e., should males discontinue methotrexate?
So where was the question? I missed it. Should the men come off of methotrexate? Was that the question?
Yes, I believe that's what they're asking.
No, yeah, no. We're lucky, I guess, in the sense that it does not appear that the paternal use of DMARDs, disease-modifying anti-rheumatic medications, affects the growing fetus, which is great. There are only 2 drugs that have been flagged as potential concerns. The one that's a potential concern is a sulfasalazine. Again, for the majority of men, this is going to be fine. But in some men, sulfasalazine can reduce sperm production. So just something to flag if, you know, a couple is experiencing difficulty with getting pregnant and the man is on sulfasalazine. And then we know the drug cyclophosphamide, which is also used for some cancer treatments and some severe forms of arthritis, can also affect sperm production and sperm quality. So men who receive cyclophosphamide need to either bank their sperm or wait at least 3 months after completion of cyclophosphamide before fathering a child.
Thank you for that information. We have a lot more questions. Do we know if or how an arthritis flare affects the developing fetus?
So the arthritis itself, okay, so yeah, like arthritis itself doesn't affect the fetus, but the amount of inflammation that mom has, we know certainly can affect the fetus. And that was the stuff that the research that Dr. Vera was talking about, that women certainly who have active disease going into pregnancy or have experienced the recent disease flare, so the disease is not like quite well controlled, those women are more likely to experience pregnancy complications. And that can be anything from the baby being born a bit prematurely, being on the smaller side, and then depending on the type of, again, arthritis, having higher rates of cesarean delivery, and having higher rates of hypertension in pregnancy, preeclampsia.
Thank you.
So
we still have quite a few questions, so I would like to remind others to go into the question portion and upvote. We only do have a few more moments left for questions, so it's really important that we answer the questions that most of the audience would like to hear from. And we're unfortunately sorry if we cannot get to your question today. These are great questions, though. Now we have one for the 14 patients that were not given the green light to become pregnant. What are some of the reasons that these patients were not given the okay to become pregnant?
So some of the reasons are, at the time they might be on medications that is not safe for pregnancy or is not safe for the developing fetus. Usually, like, that's one of the biggest reasons. So we give the patients alternative in terms of other medications that they should be on or can be switched to prior to pregnancy. Usually when we recommend this switch, we first of all, as a lot of you may know, like, most of our medication takes about 3 months to take effect. So we definitely recommend waiting 3 months to make sure that the new drug is working instead of like the previous drug was on. So for example, if somebody was on methotrexate and we're switching them to, say, hydroxychloroquine, sulfasalazine, or a biologic, we want to give them at least 3 months, ideally 6 months, to make sure the new medication is tolerated and works well. And then, we give them the green light. Sometimes we advise patients not to get pregnant because they have really high disease activity. And as I mentioned, having really high disease activity can be detrimental to the health of the pregnancy and impact the growth of the baby. So we recommend working on a better plan in terms of like getting the disease under control. And I've just really had, like, I can count on one hand the number of patients that I've just told them, I just don't think pregnancy is a good idea for you. And these are patients who've had really, really bad disease, that if they flare up in like pregnancy, it could just, like, the mom something really bad could happen to the mom. And again, this is a very rare thing that occurs, mostly in vasculitides. Sometimes patients who have, really poor kidney function. And then it's definitely not a decision that we take lightly or a recommendation that we take lightly. And, we can certainly revisit it. So, but I find, like, moms or moms to be tend to be too selfless at their own at the expense of their own health. And and one of our male patients was asking the question, and I would like to always recommend for patients to come to the visit with their partners, to have a little bit of a sounding board. I feel like sometimes women are like, I just do anything for my baby, I just really want to get pregnant. And I'm a mom of two, so I get it. But, especially, your health is also important. You're also, you might have another child, your partner is there. So it's really nice to have the partner there to, like, kind of put things into perspective, take notes, have a second set of ears to, like, kind of hear what we're saying as well. So, yeah.
That's a great answer. This is another great question. These are such great questions. What about psoriatic arthritis in terms of disease activity during and after pregnancy? Do people with psoriatic arthritis tend to go into remission too?
So the majority of the research that's been done to date has focused on rheumatoid arthritis and lupus. So we don't have as much data when it comes to psoriatic arthritis, but the available research, it shows that it's a little bit of a coin toss, in the sense that about 50% of the patients tend to do like how they were doing before. So if you go into pregnancy, you're doing good, you continue to do well, and vice versa. 25% tend to get worse, 25% tend to get better. But their psoriasis, most people with psoriasis will tell you when they become pregnant, their psoriasis like goes down significantly. But then postpartum, they can have a flare up of their skin disease.
Thank you. I believe we have time for about one more, maybe two more. We have 3 votes. Are more biologics and biosimilars as more biologics and biosimilars come on the market, will the research continue looking at the new meds and their safety?
Amiri.
Okay. Yes, and actually that's the current research that we're doing right now. So please stay tuned because that will be coming in the next couple of years.
Excellent. We have another 3 vote. When you say well-controlled, does this mean well-controlled from a biological standpoint? What about people that have always been seronegative?
No. So we mean from a clinical standpoint. Again, for those of you with rheumatic diseases will know, like as rheumatologists, sure, we care about, antibody profile and CRP, but that's not the whole story. But we also like ask you, like, how much morning stiffness do you have? How many tender and swollen joints do you have? We examine you. So it's really that whole clinical picture. Do we think as a whole is the patient's has low disease activity, or do they have kind of high disease activity with many swollen joints and high burden of inflammation?
Thank you. I think we can fill one more in. You mentioned risk to fetus. Do you know if women with an autoimmune arthritis on or not on meds have changes to placenta? Is that how growth of baby is affected?
Mary, do you want to? I'm not sure. So do you measure if I'm not aware of any research that's been done looking at the placenta of women with arthritis. So we kind of hypothesize that it has to do with like the burden of inflammation that mom has, and definitely placenta connects the two, so placenta has something to do with it. I'm not involved with any placenta research, and to be honest, I'm not aware of anything that's been specifically done.
Thank you. And one more, and then we're off to the video. You mentioned estrogen can really impact flares. Progesterone increases significantly in pregnancy. Do we know whether or not taking progesterone can decrease flares or possibly keep the disease in remission?
No, I'm not aware of any studies that have been done specifically looking at the role of progesterone.
Thank you. So we are finished the Q&A portion. We've had so many questions. That was a lot. Thank you so much for answering those. Now, we would also like to thank our Arthritis Research Education Series sponsors for their support. These include AbbVie, AstraZeneca, Biocon Biologics, Fresenius Kabi Canada, Celltrion, Biogem, and Organon Canada. Finally, a special thank you to our presenters, Dr. Mary de Vera and Dr. Neda Amiri. And a special thanks to Jennifer Pilak for sharing her story of living with arthritis and pregnancy in the video you are about to see. For those who haven't had the opportunity to visit our website and check out Arthritis Research Education Series, I encourage you to do so at arthritisresearch.ca/learn. We have episodes on a variety of topics, as well as research, resources, frequently asked questions, and more. We will be sending you a quick survey and hope you will take a few moments to fill it out. Your feedback helps us develop future education series episodes, and everyone who completes the survey by December the 12th will be entered into a draw to win a $25 Amazon gift card. Now we will play episode 15 video for you. It's approximately 7 minutes long, so please enjoy.
I was about a year postpartum after having my first child. I noticed that I was way more tired than I thought I should be by that point. And I also was waking up with stiff hands and feet and noticing weird symptoms like tingling. That was scary. I just thought, you don't really imagine your life with that you're gonna have an autoimmune disease. I thought, I'm pretty young, I'm in good shape, I have always taken care of my health. I'm Jennifer Pelak, and I am living with rheumatoid arthritis. Pregnancy and birth can trigger or turn on rheumatoid arthritis. And just the idea of having to be on medication probably for the rest of my life was something that scared me. I was scared of side effects. I was scared of what my life would look like. Am I gonna be able to be the mom I wanna be? I wanna be present, I wanna be with her, and when you're not feeling well, it's hard to be present and just fully be paying attention and giving your toddler that undivided attention, and they really need that.
It's definitely possible to have an inflammatory arthritis or a rheumatic disease and still have a family and be pregnant. The message that we have tried to instill in our patients is that a planned pregnancy is the best pregnancy. Ideally, going into pregnancy, we want to have low disease activity or have the patient be in remission. And then the second factor we look at is that what medications is the patient on. A lot of medications can be compatible with pregnancy and safe in pregnancy and breastfeeding, but some of them are not, and we need to be able to plan for that so that we transition the patient onto pregnancy-compatible medications before they proceed.
Back when I first got diagnosed and we were discussing medication, I knew at the back of my head that we were thinking that having a second child would be a possibility. And I talked with my rheumatologist, and she gave me a few options of medication, and I started on one of them. Both options were safe.
And when we talk about safety, we're talking about the baby, and we're also talking about the mom. We were actually one of the first research groups to show that taking biologics during pregnancy by a woman with arthritis does not lead to adverse outcomes. So these adverse outcomes that we looked at included preterm deliveries, small for gestational age, and congenital anomalies. Like, our work has shown that it impacts whole families. And that's why when we speak to this research, we call it the family study. It not just impacts the patients, it impacts the babies, and then it also impacts the partners that are supporting the patient.
In the early days before my medication was really working and I was flaring a lot, that was really tough because I was still on mat leave and my husband works from home. And so there'd be weeks where almost, every day I'd need him to stop work and help my daughter. And so now he's got added stress, trying to juggle taking care of my daughter and making sure that I have time to rest. And we're just trying to find that balance with each other. And that can cause tension because you add more stress to your life and it affects both people. My relationship with my partner overall has been really positive through having this diagnosis and navigating living with rheumatoid arthritis. I feel like it's drawn us closer together because I've had to advocate for myself and speak up and explain what it is that I'm going through and what it feels like. And he's learned a lot, and we've had to adjust and shift things with each other.
It really just highlights the misconceptions about arthritis being an older person's disease. So when we were doing these focus groups with women with rheumatoid arthritis, one of the recurring themes that coming up is, what about our partners? How they're involved in this family planning, and this affects them too. The partners are also experiencing knowledge gaps. They also have needs. They also have impacts on their mental health, sometimes helplessness because they're watching their loved one go through these very difficult decisions. They too need information about arthritis and pregnancy and how they can support their loved one.
Most of our diseases do not affect fertility or a couple's chances of becoming pregnant. The only exception to that is that some data has been shown that patients who have rheumatoid arthritis or ankylosing spondylitis, it may just take them longer to get pregnant.
but it's really important to have the conversation early and kind of make a joke with our patients that, even before your partner, we should know if you're planning to have kids.
Arthritis can strike during childbearing years for females and males, and we need to care about pregnancy because active arthritis is actually a risk factor for many adverse pregnancy outcomes. There's research that has shown that when a female patient is in flare, they're more likely to have miscarriage, they're more likely to have preterm deliveries, and these are all the outcomes that we try to prevent during a pregnancy.
I do worry about the impact of me having RA on my daughter, and I've already noticed that she's, a very caring person, and she'll sometimes go and make me a pretend medicine drink or something to help me feel better, or come snuggle with me. And I can see that she worries that I'm not there, I'm not around. Why is mommy resting? So I worry about her worrying. But what I'd love for people to know is that there are amazing people out there doing research, working to help us live really great lives, and there are a lot of options now because there's been options for me, and I can get pregnant, I can have a family, I can work, I can live a pretty normal life.